Welcome back. This is a unique podcast in which one of my former pain exam alumni who took the boards, took the pain exam review, and a few other reviews reached out to me to discuss board prep, maybe collaborating on academic endeavors. And so I invited him on the podcast. I hope you guys find this interesting. Before we get into it, we have a May 17th ultrasound course in New York City. I'm going to most likely be at ASPN as well as Pain Week. At Pain Week, I'm lecturing on regenerative medicine and ultrasound, guided interventions in your pain practice, and regional anesthesia. We also have Latin American Pain Society coming up, a lot of good things. But I also wanted to tell you about the opportunity to shadow me or my partners at my office where we do ultrasound and fluoroscopic guided procedures. If you have any interest, please reach out to me. Look forward to meeting you.
It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the Pain Exam Podcast, and thank you for joining us. Today, I'm joined by interventional pain physician Hamid Sadeghipour. Welcome, Hamid.
Thank you so much. Thank you for having me.
And Hamid and I, we connected via the board prep platform, the Pain Exam. And Hamid gave me some honest and real feedback about some of my questions. And I actually happen to agree with him. I think one of the contention points we discussed about the board prep was some of the pelvic pain and headache questions and chest pain questions or HIV questions, which did not really appear on the boards, but they did show up on my review. And some of those questions I happened to get from the books. But that the pain management books at the time I was writing it, and I figured even though I'm updating this thing every year, I just leave those questions in because I figured it couldn't hurt. Might stress you out a bit when you're practicing. But anyway, Hamid, why don't you just tell us a little bit about the board prep experience and feel free to share what you'd like to say about it and your prep journey.
Yeah, so basically I shopped around for a good amount of time, as we all know that when you get to job, the difference between the pain exam and compared to the other one that we have, or maybe oral board as well, is at this point we have a job. We are not, resident anymore. So the time is very
Hamid, I'm
limited.
sorry to interrupt you. You're an anesthesiologist, correct?
Yes, I'm
Okay.
an
So he
anesthesiologist.
meant the oral anesthesia boards, which a whole
Right,
nother animal.
right. Or another animal. And I did critical care fellowship too, but that's another animal too.
Right.
And top after the other one. Yeah, so I shop around to make sure that with the time that I have, I can do the best to utilize my time. And basically, I come with three good resources that actually it worked great at the end. Those three was Huntoon book is the book with, and I'm gonna get a little bit description in each of them briefly. And if needed, we can go deeply as well. So Huntoon book is a somehow 800 question, covers most of the topics. It's written like many years ago, to be honest. And I actually met Dr. Huntoon when I was looking for a job. And then I asked him like, why you're not basically revising this book. It seems that he's busy, that he didn't have enough time to revise his book. But it still, I think, is a good source. It has a good explanations. It just a hard copy is not anything online. So it just needs a little bit patience to go over those questions when you reading it. So I know that many of our folks is not friendly with hard books, but this is the only version that exists.
Mm-hmm.
The second one is Board Vitals. It has around 700 multiple question with answers. The answers is not like what like UWorld or other prep that we had for anesthesia. Their answers are very short and concise, so it's easy to go over them, and covers questions, but it has some lack of some subjects that doesn't touch at all. Then we come to basically pain exam, another resource that covers the area that mainly some of the like board vital doesn't cover, but then gives you some areas that I didn't see any question coming from those. So maybe is like a little bit over prep you for those areas that doesn't exist in anesthesia. But I know that you already, this the aim of this one is for probably other pain boards as well. I'm talking about ABA, anesthesia board exam,
Gotcha.
which Huntoon and board vitals are mainly for those anesthesia ABA exam, but pain exam is for covers the other ones as well. So those are three that I went through all them, and I actually. I don't want to bring like exact percentile, but among whatever I did so far in my exams, that was very highest percentiles that I surprised me actually. So I did well on it.
Good. Congratulations.
Thank
That's
you.
great. So tell us about your practice.
So my practice, that's a other funny story that like when you come to the job, it's, you just open a door that is not familiar to us, and no one during our residency or fellowship speaks about details of these jobs. So I was in LA. I did my residency and critical fellowship at Cedar Sinai, and then I did my pain fellowship at USC. Then I got the job offer in St. Louis that is supposed to be a brand new surgery center. And that's how they attract me to come to Midwest. And but when I came here, unfortunately, that didn't exist. It was full of grass. They made it so green. So
Wow.
because it was during the COVID, and that plan, unfortunately changed. So I have a very strong background in research. So I wanted to be an academic, and as you know better than me, academic pain, the turnover is not that much. So whoever goes there stays. So job is very limited in pain academic. So this was, attracted me because it was academic. It was, surgery center, pain, but didn't exist. So I ended up, but I have at that time two child. Now I have three. So it was family move from LA to here. But I was lucky that there was a bunch of, private practice around me as well. So what I ended up doing, I kept my basically FTE as full at the beginning. Then I decreased it to 60%, and I'm now doing 40%, which practically is around 50%. So I'm doing 50% anesthesia and regional in a big academic center, which I work with the residents. I do, lots of research with them. I'm so happy with that part. And my private is nurse practitioner. I have four nurse practitioners. We have four offices, and I have four nurse practitioners, four MA, and my own team has like five, six other people, and they have an algorithm that they go over it, and I help them to see the patient and follow up. So that brings a room for my time to mainly do procedures. So when I'm basically there, I do mainly like, around 30 procedure per day on average. So it's very heavily procedure based. I can later on talk about how, in my view, in the last 3 4 years, the pain practice has been changed nationwide, and what I'm thinking the way that this goes, because I'm thinking the fellows that from our program went to the pain fellowship, and the resident that I'm talking to and trying to convince them to go to pain, there are some barriers that I can talk to them as well.
But before you go there, a question for you. So you're working for an academic anesthesia practice part time, and they're okay with you doing your own private pain practice on the side, not related?
They are, because basically I went down for my FTE. So as far as your FTE goes down, that's fine. I mean, they don't care about the time that you're not there, the time that you're there, and I'm not doing pain in both sides, so it's not competitive to their practice. It's actually Cross the River, which is Illinois side.
And do you think you'll transition to full-time pain eventually?
I like it. It just I haven't found the right position to cover a little bit of academic, a little bit of research, and the pain at the side. So, and if I have to, like everyone else, I mean, financial aspect of it is very important when you're, young and you have family. So I have to careful about what contract I sign, and I don't want to like ended up being in a place that do 2 years and then don't become partnership, and at the end I lose money as well.
Yeah, I'm sorry. So your pain practice is with others, like it's a group practice, or it's on your own, or it's a partnership track, or
It's a group practice. But I'm the main pain physician there, so I'm basically director of the pain platform. So I'm managing all of the procedures and algorithm and the protocols and guidelines and everything. But obviously, that's not permanent like many other jobs that exist there.
hmm
But as of now, I'm happy that I'm doing both. I'm not sure if that's going to continue anytime, but I live at the moment, and at the moment, I'm happy.
Well, that's good. I mean, it sounds like you figure out a nice little niche in both worlds. You're dabbling between both worlds, sort of like what I'm doing in a way, but it's really just for one practice. But um, to get the best of anesthesia and the best of pain, hopefully not the
Exactly.
worst of each one.
Right, right.
But so how do you see the landscape of pain management changing in your practice over the last few years?
Right. So the main thing is the way that Medicare and all of these, private companies are insurance companies are going. It seems that they're paying more attention to surgery center, and they paying less attention to office-based procedures. So by
In
that,
terms of restrictions or in terms of like, I mean,
in terms of reimbursement, so like just example, so if you want to get X amount of money, you have to do, let's say 30 procedure per day, which is a full day procedure to get that amount of money. But you can do one SI fusion, you can do one kypho, or you can do one or two implant in a surgery center, and you can get maybe 3 times more than that, which takes like 2 hours of your time
if
compared
you own
to
the
eight
center, you
hours
mean, if you own the
if
center.
you exactly if you own your center. So that's why for most of the people that I know of, they trying to basically shut down their offices, or they being a partnership with their ASC and moving towards that path. And because the bigger reimbursement exists in those big procedures, your practice needs to go towards that path. That's why nowadays many people are doing SI fusion, mild. I don't want to name all of these, specific brands, but there was a brand to, do the jacking this, transfers process. There was a bunch of brand there. Now they moving, shifting to other things. So that's bring two things. One is you have to be, capable acting as a surgeon now, because now you're microinvasive spine surgeon, microinvasive ortho surgeon. And unfortunately, in our fellowship, 1 year fellowship, not many people get enough confident to doing those procedures. That's one thing. The other thing is basically the partnership of that ASC becomes more and more tricky when you're dealing with ortho group, and you're dealing with the spine group that's have more power. So that's why at that same time, I have to be honest, at the same time, anesthesia market is so hot. So
Yeah.
post COVID, anesthesia market, I mean, changed tremendously. Like I was offered like locum job by like X amount per hour. Now is 2x. Easily I can get any job locum, even with 20 or 30 minutes drive, with 2x amount of hour. And that counts, like, just imagine how much that will add up in a month or a year.
Oh yeah.
So when I'm trying to convince my resident to go to pain, the first question is like, okay, financially, if I go to pain, I'm going to end up with this amount of money. But if I can go to anesthesia, is this. Second, if I go to the pain, I'm not going to get confident at the end, because, in 1 year fellowship, they have to train you to how to hold the needle, how to do epidural, this transforaminal, this and that. And there's no time to train you well with all of those big surgeries that you needed when you sign up with a big practice and that owns a surgery center. They
Right.
want you, they want you to do SI fusion. How many of anesthesiologists are comfortable to do SI fusion? I don't know. Probably you know better than me that answer.
Not
But
enough is
that's
the answer.
right, right. So that's a shift that unfortunately is going through, and I hope that ABA, soon address the issue, because it's just changing everything. Like because I see less and less interest, unfortunately, in pain fellowship these days, which in my year, like even 4 years ago, it was one of the top fellowship in the
Right.
country, like even compared to like fellowship in the surgery, fellowship in other fields, anesthesia fellowship pain was top. I mean, it was very hard, very competitive to get in, but these days are not. It's getting down, so I'm seeing it going down, to be
It's
honest.
also very saturated. It has so much working against us because you have people who have no business doing epidurals, trying to learn epidurals. People, I teach these courses, and sometimes you see people like an internist will come into the course and say, "Oh, I'm here to do epidurals." I'm like, "You're not doing an epidural here." I'm like, "If you want to learn about it, I'll talk
Yeah,
to you about it, but you can't just go to a weekend course and learn epidurals. You want to learn a knee injection? Sure, anyone can do that." But like, the big spine procedures or some of the high level stuff, I taught a course, an ultrasound course a few weeks ago, and not to, get on anybody's case, but an internist came and she wanted to do stellate ganglions. I'm like, well, okay, why? She's like PTSD, and I understand they want to help patients, make some money. I get that. But I'm like, first of all, have you ever held an ultrasound? No. Um, you don't you don't even know. The problem is they don't know what they don't know. They don't know how dangerous it is, and how high it's one of the highest level ultrasound procedures we do. So I completely discouraged her, and I told her to focus on the knee injection, and I think she understood and she took that away, so. But I mean, it's uh it's scary because they've also in different states CRNAs, PAs, nurses, everybody is allowed to, they allow them to do almost anything in certain states. So um and then you have the insurance companies, trying to pay us less. So you have so many different things working against us.
absolutely. I totally agree with you. Yeah, I mean, like just ketamine, like ketamine clinic, like they all think that they can, infuse ketamine without any issue. So nurse practitioner are doing it, some internal medicine doc doing it, um, psychiatrists doing it. So it just, and they give Versed, like 4 milligram Versed and ketamine infusion. Barely a patient can breathe. So
Wow.
it just, it's very hard. So when I think we need more regulations on all of these.
Absolutely. And it's at the end of the day, I blame the government because I really think it's or the societies or the state governing bodies. They're the ones who are supposed to protect the specialty. I mean, people are learning think procedures on YouTube, so there's only so much regulation we could do of ourselves. If they're gonna read an article about ketamine and just do it without any qualifications. So, I think the scope of practice needs to be more clearly defined. Um, but so, okay, so are you doing regenerative medicine?
Pardon me?
Are you doing regenerative medicine in your procedure
Yes, I do.
or your practice of it?
Yes, I do hyaluronic acids for knee. We have actually our office has a patency for like 25 years on that. So we have a very defined, nice because all of our four offices have PT inside, on-site PT. So that's why they get the injections, they go to the PT, they come back. So that's one thing. And then recently I'm moving more aggressive about PRP. Actually, I tore my ACL 2 months ago in soccer play. Don't ask my date of birth, but that I play soccer and then I just tore my ACL and I did 2 injections so far for myself. And then my PT was couldn't believe that the progress that I'm making. So it's I think it's really helpful. It's still the out like it depends on who reads which article but for something that doesn't have any harm and there's lots of background research on it I really excited about it at the same time I started collaborating with one of the famous lab at the SLU that they're trying actually to make an artificial PRP so
Oh, interesting.
it's a very big collaboration that I made so I'm trying to help
When you
them
say
to.
artificial PRP, what do you mean? They're getting
So
it's
basically,
from.
the goal is to make it as a powder, so it doesn't need to be autologous. So, but can be like as a powder, and then you can basically mix it before injection, and by at the molecular level, and the
It,
conjunction that can make and the solubility that can make is something superior to any hyaluronic acid
so
than
it's
any
not
PRP.
autologous, you're saying. It's like from
Yeah,
somebody.
it's exactly. It's from some.
So,
You can buy it.
well, at that point, it kind of sounds like it could be exosomes, because exosomes are like really how this stuff works, right? It's what the
Right.
platelets secrete, so or stem cells secrete. So, interesting stuff. I mean, where do you see the specialty in 10 years?
I think we're gonna be a uh, small neurosurgeon, a small orthosurgeon, and a little bit epidural at the side. But the problem is their society are strong too, and I'm sure they go to DC and they, lobby as well. So it depends on at the end who beats the battle.
Right, right. In New York, some of us are doing these fusions, but not as many as outside New York. I think outside the state, New York State, you have a higher percentage of doctors doing the more minimally invasive surgical thing. Part of it is reimbursement. Part of it is pushback from the ASCs or from various practices. That's my opinion. I don't really have stats on that, but I do think you're right. I think we are moving towards neurosurgery and more regenerative procedures. And I think at the end of the day, it's really kind of the way the regulations go that are really going to shape the way healthcare is going. Dropping reimbursements, I think more and more people are going to be paying more cash for their care, unfortunately.
Right, right. No, absolutely, because it's just a battle. It's just, hard to deal with all of these insurances. Like for simple like injection, you have to each of those like insurances have like different algorithm, different pattern. They required MRI, one required PT, one required this, one required two injection before doing this, one required five injection before you jump into this. It's very hard to keep a track of all of these different, insurances, and at some point you just gave up.
Right, right. Yeah, that's their hope. They just want to confuse you so you can't figure out.
Right.
Anyway, Hamid, I'm going to wrap it up soon. Is there anything else that you want to say to any young pain physicians out there listening, or maybe even the older guys and girls?
So I think the new generation are the one who gonna build this practice, and we just need more motivated people that can work with their hand, but as well, good as well, and don't be disappointed. I mean, the good example for it is radiology. So when I was at Brigham around 2016, I was actually in the surgery program at Brigham. At that point diagnostic radiology went so down. There was unfilled, like I can like even 100
Wow.
maybe spots that was unfilled. And when I talked to all of these folks there, they were concerned. But what they did basically, they review everything. They published a couple of data. They said, okay, in 5 years, if you continue this, the diagnostic radiology will die. And that's how basically they come with the idea of intervention to be started at the beginning, not waiting for 6 years and then having at the subspecialty. And they work so hard, their society works so hard, and now is back to the track, and they earn as much as they were earning before. Otherwise, the slope was so bad, no one had motivation to go, and they were saying, "Oh, you can send a radiology report to oversee, some Middle East, India. There are some people there, they can read it faster than here, but they took very seriously, and they hold it so hard, and they didn't lose a job, and they didn't lose this that practice. So I think what we need is the same thing. We should be keeping hope, but we should work hard. Our society, ABA and other pain societies should be united to each other, and be strong.
Yep, sounds good. Well, I thank you for coming on the show. I think I 100% agree with you, and I hope to see you at the upcoming conferences, either ASIP, Aspen, Pain Week, NICIP, Latin American Paints, whatever they keep going.
Yeah, right.
There's so many conferences. But anyway, it was really a pleasure to have you on the show. Hamid has also volunteered to write some questions for Pain Exam. So I want to thank you for that. And anyone else out there who's looking to contribute, please let me know. Thank you, Hamid. Have a great evening.
Thank you so much for having me. Same to you.
My pleasure. And we'll be in contact.
Absolutely.
All right. Take
Bye.
care. Bye.
Take care. Bye.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.